and welcome back to Voices for Safety. Today, we are going to be talking about healthcare and patient safety challenges for a very specific population, prisoners in the UK. As you know, in this podcast, we explore real-world research on health inequalities and patient safety challenges. Research that is funded by the NIHR Greater Manchester Patient Safety Research Collaboration. In this episode, we're talking about a new study funded by the National Institute of Health and Care Research, the NIHR, that exposes key failures in prison healthcare. The study shows that the prison population in the UK are up to 67 times more likely to experience avoidable harm when accessing healthcare. By avoidable harm, we mean issues, injuries, and illnesses that could be prevented and should not happen, but they are happening because appropriate systems, standards, and processes are not consistently in place. The study that we're talking about today has recently been published in the journal BMJ Quality and Safety. It highlights the complexity of health needs within the prison population, the pressure on the NHS, and why it represents a broader public health and patient safety challenge. So I'm delighted to be talking today with three members of that research team that conducted the study, who will be bringing different perspectives to this discussion, and I'm going to let them introduce themselves to you now.
Thank you very much. So my name's Dr Joy McFadzean. I'm a GP from Swansea, a clinical lecturer of patient safety at Cardiff University, and I'm the Associate Director of Learning at the WHO Collaborating Centre for Patient Safety, Learning and Improvement, which is within the Division of Population Medicine at Cardiff University.
My name is Dr Jake Hard. I'm a GP and have been working in prisons for about 20 years, a range of different prisons in England and Wales. I'm currently the Associate Clinical Director for the South West Prisons for Oxley's NHS Foundation Trust, so that's covering 9 prisons. And I'm also a panel member for the Independent Advisory Panel on Deaths in Custody.
Hi, nice to be here. I'm Dr Verity Wainwright. I'm a lecturer and the Deputy Programme Director for the MSc in Forensic Psychology and Mental Health at the University of Manchester. I'm a researcher whose background is in research across the criminal justice system, focusing on understanding risk, improving care around the topics of physical and mental health and suicide and self-harm.
So thank you all for joining us today for such an important conversation. I wanted to start really with the broader picture of the healthcare challenge that we're talking about. So Jake, can I come to you first, and can you tell us what the challenges are in prisons and why this study was so desperately needed?
That's a really great question. Thank you. It's important to note prison healthcare is extremely complicated and relatively new compared to wider primary care. So it's still an evolving part of prison medicine, if you like, is still evolving. I suppose it's a good place to start to think about our patients in prison. They are essentially entirely reliant upon the healthcare services within the prisons in order to deliver their care. So where in the community, people would have a choice to take themselves to A&E, to the GP, etc., or out of hours over the weekend. In prison, they're reliant on those healthcare services in there. So they have less choice about where they could take themselves. Healthcare services are commissioned differently to what's available in the community in terms of general practice, particularly primary care. So reliant on that commissioning arrangement to put the providers in place, particularly in England. And there are different arrangements in Wales, Scotland and Northern Ireland. So I'm not going to go through all of those. But those commissioning arrangements means that there's changes in how the teams are configured and the different parties that are involved in delivering that care. And what you ultimately see is a broader range of services available inside the prison. So primary care, dental, optometry, physiotherapy, and in some cases other in-reaching services are also available there. But what this means is there's a greater variety of potential barriers and, if you like, fractures or gaps within the system that can occur. That doesn't mean they will occur, but can occur as people move into the prison system as they come in, between prisons, if they're being transferred, or sometimes on release as well. There can be issues relating to that. So these are areas where there can be added risks. And obviously this paper focuses on some of those barriers and some of the risks associated with that. So as I've sort of just to summarize, it means that the care that we're providing in prisons ultimately appears to be more complex than people may be familiar with relative to the wider community.
Yeah, and I think there's probably a lot of people out there that don't even know that exists, that they think that if somebody is in a secure environment that they have a healthcare need, that they're sort of taken out of that environment and maybe taken to a hospital, and they don't really fully understand that these services exist within those settings, and then the issues of transition between those settings as well. So this is the first study to estimate how avoidable harm occurs in prisons. Or in prison healthcare. So, Verity, can you tell us more about this research project and what you did?
Yes, so you've mentioned it was funded by the NIHR policy research programme, and it's a collaboration between 3 universities, the University of Manchester, University of Nottingham and Cardiff University. And the project was a large-scale mixed method study that ran for a long time. The part of the study that we're focusing on today was a case note review. So it involved us accessing the healthcare records of people in prison. So we had a team of nurses who screened healthcare records of people across our prison sites to identify those that were at risk of avoidable healthcare associated harm. And then the records that were identified by the nurses were then reviewed by 2 GPs to identify where avoidable harm had occurred.
Wow. So is that 2 GPs for the entire project, or 2 GPs per site?
Yeah, so we had many GPs that collaborated in this work.
Good. So can you tell us more about this work? So you looked at, was it 15,000 prisoner health records? So what was the data that you were looking at? So when we're talking about avoidable harm or potential for avoidable harm, what is that data? What is it you're actually looking at in those records?
I think the question about how many GPs as well will make sense when I would give the figures in terms of what was involved. So the nurses screened 15,027 records, and then the sample that went through for the GPs to then review was 7,147. So we're talking about a lot of records. So the GPs reviewed those records for each person in the sample across a 12-month period. And what we asked them to do was to record information about what happened, any contributory factors, but also how severe the harm was as well. So they were asked to rate how avoidable the harm was on a 6-point scale, from whether it was definitely unavoidable to definitely avoidable. The reports were then analysed by 2 academic GPs with experience in patient safety. So Joy here as well took part in that. And that was to agree harm severity, but also there was collaboration with experts from primary care and from prisons to make sure that the ratings were contextualised properly.
Amazing. Can we talk about your research findings then? So what did you find? Out of all of that data, what have you found?
We're looking at everything from medical consultations, looking at their medication records, any prescriptions, whether they've been referred for any specialist care, have they had any tests or investigations. So we had access to all of their primary care records, and we were looking for any evidence, as Verity said, about healthcare associated harm. So these are any instance where a person in the prison could have experienced harm or did experience harm in this case. So that could have been physical harms, that could have been psychological harms. And we found 247 cases of harms across those 7 or so thousand records, which were experienced by 244 prisoners. So even within that, there was a prisoner or more than one prisoner who experienced more than one discrete safety event as well. And what we were seeing is that they were experiencing delays in accessing healthcare professionals, delays in management of care, and that led to them having problems where they'd been left in pain because they're waiting for tests or referrals. So to give you an example, most of the harms that we saw were considered to have resulted in what we called a moderate harm. So this is a harm which is short term, it's not going to last forever, but it will often need some kind of interventional treatment to overcome it. And examples that we use in the paper was someone who experienced a fall and they had, pain in their leg or whatever. And the advice was that they needed to go to an emergency department for assessment and likely an X-ray. And despite that being escalated several times, it actually took 2 weeks for the person to be transported to the emergency department, at which point they carried out the x-ray and saw that there was a fracture, which required a cast and then referral to a fracture clinic. And obviously in that time, someone is left in quite a lot of discomfort. We know that even just having a cast on a fracture can really help in terms of pain relief, and acknowledgement that this is actually very serious and someone needs some extra support. So those are the majority of the harms that we saw. But the second most frequently occurring severity of harm, or the duration and the impact of that harm, were directly involved with the death of the prisoners as well, especially with regards to self-harm and any kind of thoughts or symptoms of suicide and suicidal intent. So, these are significant harms, which it's really important that we overcome those in the future as well.
Absolutely. In terms of the patient who had the fractured leg, is there any insight into your data, any patterns that might explain why that sort of 2-week delay was the case?
So in many of the types of report, including harms, there were some contributory factors, which are the type of explanations for why something is happening. So, for example, the case with the patient with a delay in attending the ED, it was often because of problems with staffing. So they may have said, yes, this person needs to go to the emergency department. We need to arrange 2 escorts to take them to the ED and arrange appropriate transport, but then something might supersede that. So another emergency may come through, which means that is delayed. Or at some points there may have been a prison lockdown, which meant that, everything halts while security constraints are overcome. So we can't say always why these events take place, but from what we did see, that it was often issues with staffing and also an escalation. So if on one day the escorts were cancelled, we weren't seeing that anyone was documenting that was being escalated, that was going up the chain of command to say, this person didn't go yesterday, are they going today? How do we make sure that happens? And I think, it's not documented again, but if the prisoners themselves are not raising their concern every day and saying, I'm still waiting on this, perhaps because they can't, we can't guesstimate to why that would be, but because they're not saying, I'm still in a lot of discomfort, can you help me? And they're waiting and waiting for someone to address it, because they don't have the autonomy, as Jake mentioned, to take themselves to ED or to escalate that. Then they were just waiting.
One thing that just came into my mind is, was there any trend in the data across time for people as well? So, for example, in community, which is what I know more of, we see there are particular tricky points around transitions in care. Was there anything that was evident within your data that are more tricky times for people, or was it just variable depending on what their need was?
So it was quite variable. I can't say there was definitely one particular point, but definitely arrival and transition points between prisons was evident. So we saw that some prisoners were being transferred between prisons over 20 times in a 1-year census period.
Wow.
And if they have additional long-term health conditions, they need any type of, healthcare monitoring, or if they've presented with anything which requires secondary care input and you're sending off referrals, every time that someone is moving around and they're not being placed on a medical hold for lots of different reasons, whether it's due to overcrowding in one prison to be moved to another, then we can't expect any type of continuity of care because they are moving around so much. So what we were seeing, especially with abnormal blood results, for example. So on arrival, if they're offered any type of bloodborne virus testing, thinking about hepatitis, for example, we saw that there were people residing in prison who were testing positive for hepatitis C on arrival at a prison. They would send off a referral perhaps to secondary care and think about next steps. but they might be transferred to another prison before that referral is sent off. Or if they are released and then they return to a different prison, they notice at that point, oh yes, they're still testing positive for hepatitis. And now that there's actually abnormal liver function testing because of the condition. And yet another referral is not being sent off because we don't know how long someone's going to stay for, or perhaps it's just been missed on arrival again. And if they're going from prison to prison, transition point to transition point, in and out of the community, it's very difficult to know who has ownership of that result and who's taking responsibility. And I think the risk is that you're going to fall through those gaps if someone doesn't have that oversight. And every time they come in, I think that the prison teams are doing excellent work, but they need more time. They need more funding to focus on each individual and their healthcare needs.
When you said, and this sounds like it may be one of the more extreme examples, but a movement of 20 times within 12 months for an individual, is that an extreme example there? Or is it common for prisoners to be moving between settings?
Yeah, I mean, movement between prisons is definitely common. The entry points for the male estate are the Category B local remand prisons. And once your court case is concluded, if you're sentenced, you're generally moved on to another category prison. So inherently, there's almost always some form of transfer at some point. And as indicated, there are some people who transfer quite a lot for various reasons, security reasons. And I think it's important to highlight that those are ultimately the decisions of the prison service. So health doesn't usually have an option to influence that. Joy has mentioned medical hold. And while that's advice to the prison service, it's not cast iron guarantee that somebody won't be moved. And linked to that point is, if you discovered the scenario given, somebody's got a hepatitis C, but they've actually moved prison, the healthcare provider who did the test doesn't necessarily know where that prisoner has gone. Obviously, that begs the question that the provider that's now looking after them should know about that result or look back in the records and see that positive result. But if that result came to me and my patient has moved on, I wouldn't necessarily know where they've gone to be able to do that. And of course, in some cases, some people are released. And just a couple of other points, if I may, just to come back. Joy sort of spoke about patients going out to hospital. Just to clarify that it is prison staff that take people out to hospital, not healthcare staff, because sometimes there's an assumption, well, a nurse will take the person out, but not necessarily for a suspected fracture, but for certainly more severe things. And it's actually the prison staff. So when there are staff shortages within the prison service, that does impact our healthcare delivery. And in addition to that, another point here, which is important about self-advocacy, is that prisoners are generally not allowed to know any upcoming appointments that they may have, whether that's for a routine referral or indeed attending tomorrow for an X-ray for a fracture in their leg. They are not allowed to know because that poses a security risk. So as a doctor, a patient may come back to me and say, I've still heard nothing about my X-ray, what's happening. I may have that information, but I may not give that to them in most cases. There are rare exceptions to that, people who have the relevant license to be able to know that information, to take themselves to that appointment in the open prison estate, but that's rare. And the common principle is that you do not reveal that information, whether it's a test or an appointment with a specialist in outside hospital.
So where do we go from here? It sounds like there are potentially numerous recommendations that you could have, or even interventions that would really make a difference to avoidable harm in prisons. Have you got any insight into those recommendations? Is there anything you'd like to tell us about?
So I think more research is definitely needed into what type of interventions will overcome the barriers. But I think a lot of that will be working with people within the prisons, and that's going to be the healthcare teams as well as the prison teams. And then the people residing in the prison as well. We need to know more about their experiences. And I think overcoming any tensions between healthcare and prison security are needed if we're acting in the best interests of the prisoner, bearing in mind the important aspect of security at the same time. So it is a balance, but I think more could be done to consider equivalence of care in prisons. And some of that could be continuously reviewing medical records in this way that we did in the case note review. Now, this was a long-standing study over several years, but that's not to say that individual teams can't appraise their own records, whether that's in a quality improvement perspective, patient safety aspects, thinking about potentially how to use healthcare record systems to help support them to make the clinical decisions. The GPs commented that sometimes documentation was quite sparse. And, as I mentioned, it's very likely that care was being delivered outside of what was documented. And it just wasn't there, so we couldn't comment on it. We speak to healthcare professionals who work in prisons who actually think many prisoners have excellent health access, and the majority of them will not experience harm. So, from the 7,000 records that we looked at, only 200 odd harms were discovered, showing that the majority of that care did meet the standard. We're not saying that all care in prisons is considered to be unsafe, but there were certain aspects where we could do more to make sure that we're bridging any gaps so there are no health inequalities faced by people in prison. And I know we didn't touch upon this so far, but when we compared our findings to a comparable study in primary care, not quite the same, there's slightly different methodologies and slightly different focus, but we found that the rate of harm in prisons, it could be that prisoners are up to a 67 times greater risk of healthcare associated harm just for the fact that they're residing in a prison rather than being in the community. And so I think attention is needed, funding, support, research to help us to bridge that gap.
And that's an inequality, isn't it? That's an inequality that really shouldn't exist just because somebody happens to reside in a secure environment rather than out in the community and receiving their healthcare in prison. One of the themes that I think is always interesting and always comes up in no matter what setting we're talking about patient safety and avoidable harm, but communication, and whether that's better record keeping or better communication between and within staffing teams as well. Have you got any indication what better communication could look like?
Another phase of the work was to speak to staff and people in prison to understand their perspectives about avoidable harm. But there were so many overlaps between actually what was coming out of the quantitative data and the qualitative data. And you have touched on one of those, which was about communication, the need really for better systems, integrated technology systems to enable that communication, but also about the complexity that Jake spoke of, that when you're talking about healthcare, is that you have a healthcare team, but you also have a prison staff, and they've got different remits. That your prison staff their focus is security, and the healthcare staff. So the communication between the two groups of staff is difficult. Then it adds further difficulties to overcome communication challenges. So I think there is something about changing the culture within the settings as well, to think about how we can improve communication between prison staff, healthcare staff, between different prisons, and whether that is thinking, again, more about better technology systems to facilitate that.
As is being referenced here, data for personal care is something where there have been significant improvements in the last 10 or so years in terms of promoting registration for people when they come into prison in England only, which means that the lifelong record from the community can pull through if they do register, and information such as summary care record can be viewed. And that's improved the personal care element. But on release, we are now seeing barriers to people re-registering when they go back into the community, or sharing that personal data with other services such as community mental health teams or substance misuse services. So to Verity's point, better means through technology to share that personal data for care is definitely needed, but work is ongoing to improve that. And back to Joy's point about research, and I'd just like to build on that because, of course, this topic was covered in the Chief Medical Officer's report published in November of last year. And actually, there's a significant data inequivalence here, which is the System 1 data, health data that's stored within the prison system from TPP, they hold the data, is not shared into any widely available research databases. So it's not being analysed other than through mechanisms described by Joy already, which is to go in site by site. So we don't have any available aggregate data to really help us understand what is the needs of our population, bearing in mind, for example, the Mayor Estate, over 80,000 people in prison, but there's a turnover in that group of about 160,000 per year, possibly more. We just don't have that. So there's a real need to not only improve the use of aggregate data for research purposes, but, for example, also for surveillance by UKHSA, for example. So that's a really significant data inequivalence, which I think could really benefit from being improved over the coming years, and obviously would help researchers like my colleagues here.
Yeah, absolutely. It helps everyone, doesn't it, to find that pattern in the data, and access to data is always a tricky one. Thank you all so much for taking the time to speak with us today about such an important topic and a timely study. For our listeners, if you'd like to read the paper, you can find it linked in the episode notes, or you can search for it by its title, The Incidence of Avoidable Healthcare Associated Harm in Prisons in England, a Retrospective Case Review. It's published in BMJ Quality and Safety. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, Blue Sky, LinkedIn, and on our website, www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights, innovations that make healthcare safer for everyone. Thank you all for listening, and we'll catch you in the next episode.